Good evening, everybody, and welcome to another academic lecture by um, presented by SIGAF Anesthesiology. SIGAF is Surgeon Group of Africa, and my name is Dr. KK Collins. I am the anesthesiology team lead, and we are here with a lecture titled "The Unique Challenges of Providing Anesthesia Care to Children," and it will be presented by our speaker, Dr. Zipporah Gatuya. She's a pediatrics anesthesia from Kenya. Ma, please, you have the floor. Thank you.
Thank you very much. I hope you can hear me. Collins, can you hear me?
Yes, I can hear you, Ma.
Okay. Good. So today we are going to talk about unique challenges of providing anesthesia care for children. I'll start by saying that I serve on the Global Medical Advisory Board for Smile Train. I'm the Secretary for Global Initiative for Children's Surgery, and I'm an anesthesia volunteer for Children's Surgery International. I have done a lot of work in pediatric anesthesia, and now I'm doing a lot of work in public health as well. So this lecture is going to be divided into two parts. The first one is clinical pediatric anesthesia, and the other one is what I would call the public health clinical anesthesia. We'll go through these with these objectives. The first objective is to outline the challenges in pediatric anesthesia as a clinical specialty from an anatomy, physiology, pharmacological, cognitive, social, and emotional aspects. And then to outline the challenges of pediatric anesthesia from a public health outlook, infrastructure, equipment and supplies, workforce, to propose ways of dealing with this and to outline how such solutions can be achieved. I'm sure you have had a lot of times many terms that are used in dealing with children, and a lot of lay people are not very sure of what each means. So this, I'm sure, is something that you know very well. But we use the term newborn for the first 24 hours. We say neonates up to 28 days, infants up to 1 year, and term babies will be gestational age 37 to 42, and premature babies are less than 36 weeks gestational age. And these are important when you're giving anesthesia to children, and you'll see why. When we come to conduct of anesthesia, the conduct of anesthesia for these children, at whatever level you classify them, must be preceded by meticulous preoperative evaluation with history, physical examination, and investigation. Why is this important? Most of the time, when you have ex prematures, and I'll figure out ex prematures, when a baby is born at 32 weeks and they go home, people start counting at that time. So they will come back after a month. The gestational age will be 36, but the parents will tell you that this baby is a month old. So unless you're taking history to find out was this baby born at term, you will miss a very significant part of your history. So you need to know how was, especially for the babies less than 6 months before they catch up growth. You need to know were they born at term, what was the mode of delivery and why. Because sometimes you find they will tell you was born by cesarean section, and when you try to find out why, they will say it was prolonged labor, or there was meconium staining, and all these have bearing for you as anesthesia. You need to take a history and know was this baby supported respiratory wise at the perinatally. So you will find that a baby was born at term, But if you don't ask, they will not tell you that the baby was put on the ventilator because they're happy that the baby went home. And then maybe this is a kid who was intubated for a long time in NICU, and you're coming to intubate, and then you have tracheostenosis. So there are many things that you can get from taking a good history and a physical examination. The two systems that you must pay meticulous attention to: respiratory system and cardiovascular system, and the airway assessment. Let's remember that neonates are prone to hypothermia and hypoglycemia, so you have to be wary about that even as you prepare. There are common concepts in pediatric anesthesia. We shall not go into details with all of them, but we have preoperative fasting. This is the guidelines, how many hours NPU the children must be. Again, for pediatric anesthesia, it's interesting because we very well know the 6-4-2 rule, but you find that sometimes you have neonates who are being fed every 3 hours for some other medical condition or the like. And if you say that you're starving them for 4 hours, then they will be totally overstaffed. So it is good as you take your history to know how often does the baby feed, so that you plan how soon you're going to feed them. The risk of aspiration, the other controversy that comes there, especially with the parents, is the differentiation between formula milk and breast milk. And we know that these two have different times in terms of preoperative fasting guidelines. So you have to be careful about that. Premedication, if you choose to use premedication, then you need to be wary and know that you have to monitor those patients. And the other common thing is about pain control. There had been concepts that people teaching that neonates don't feel pain, but current research shows that they do feel pain, and you're encouraged to do proper pain management, even for older children. I find that sometimes in our setup, pain for children is badly managed, and we have to take charge as pediatric anesthesia providers to do that in an appropriate manner. Then in the conduct of anesthesia, we talk about induction. Are we doing gas induction or IV induction? You need to be aware about that. How are we maintaining our anesthetic? What are we using for reversal? And the all important monitoring throughout the period of from before you induce to the time you set the baby to PACU, and also monitoring in PACU. When we talk about anatomy, there are specific things that are important, especially for neonates, and that are very different from the adult or the bigger child. And we'll talk about this a little bit. They have a large head and a small neck with poor neck muscle control. So that means they are floppy. You have to be very careful when you're doing your intubation. And sometimes it can be a difficult intubation if you're not careful about how to do it. Remember that neonates are obligatory nasal breathers with the narrow nares. So any form of obstruction of the nose will cause trouble for you. So you have to make sure that as you put them to sleep, that you've cleared the nares, and even if you have to put drops, so that you don't have a problem with that. They also have a large tongue with large floppy epiglottis, which may present as difficult in intubation. Their larynx are higher, C3 neonates coming down to about C4, C5 by 6 years, and the normal adult position of C5, C6 is where it is. The length of the trachea is short, so that means the amount of tube that you want inside must be very little, otherwise you do the bronchial intubation. And they have a narrow cricoid diameter. which means that any amount of swelling of the larynx will be multiplied many times over. I'm sure you've seen that diagram about so any change in the diameter of the cricoid will increase the pressures very high. When you talk about the conduct of anesthesia, you must remember about preparation, preparation, preparation. These children do not have a lot of reserve. So if you're not well prepared, they may not give you a lot of chance. So as you go to your operating room, you must think about how you're going to prepare your theater, have appropriate sized equipment and supplies, including needles and syringes. I don't know whether where you come from you have this problem where you go into the OR and the only syringes there are 10 cc syringes, and you need to give 2 mics of fentanyl. So are the TB, the 1 cc syringes available? Do they have needles? Do you have the small needles? Do you have the small vascular access cannulas? So you really need to prepare before you bring in the baby. Temperature regulation and modalities. Remember, enemy of babies number one is hypothermia, number two is hypothermia, number three is hypothermia. Sometimes we get complacent because we think we're in Africa, it's a hot place, the babies will not get cold, but they actually do get cold. And you have to pay attention, especially when you're doing vascular access. Sometimes you can have, if you have difficult vascular access, everyone is trying a limb and the baby is exposed and can be for a long time. As you prepare for your anesthetic, please remember to have an able and skilled assistant, because this will go a long way in helping you achieve what you want. When we talk about physiology, I don't know whether you can see that slide, but it's basically about the things that will help you remember. Number one, we talk about the blood-brain barrier. It is immature. So how does that affect your conduct of anesthesia? If you think about the lungs, you have a high metabolic rate with a very high respiratory rate. So that also impugns on your minute ventilation and your reserve volumes. When you talk about the large body surface area, it means that the head, just the head alone, they will lose a lot of fluids and heat, so your insensible losses are very, very high. The skin is thin, so absorption of toxins, or especially sometimes we apply local anesthetics like EMLA. A lot of it will get absorbed if you're not careful, so you have to know how much you're giving. Kidneys, the head. So all these things you have to think about the physiology, because the physiology is developing. You will find that the liver is not fully developed at birth, the enzyme system is not fully developed at birth, the kidneys the same, the capillary leakage, and very, very important is about their circulation. So when babies are in utero, they have a fetal circulation which closes with the first breath. And sometimes when you stress them at anesthesia, they can reverse to that transitional circulation, which then gives you trouble in waking them up. When you think about what we're talking about, is if you look at the neonatal kidney, for example, it receives only 5 to 6% of the cardiac output, as opposed to the adult one that receives about 20 to 25%. So this has a bearing on your drug excretion. If you look at the high alveolar minute volume, it means that they're breathing very fast. So when you do a gas induction, they'll sleep very quickly. And when you're reversing, you'll also reverse very quickly, as opposed to the adult. And if you look at their cardiac output, it's actually very high, sometimes going up to 200 mils per kilo per minute, as opposed to the adult one that is almost a third of that at 70 mils per kilo. Then there is the new discussion that has been discussed over the last 10 years or so about the effects of anesthetics on the developing brain. And there are many studies that have been shown that maybe the anesthetics we give to these children may have an effect on their brain development. But again, as the anesthesia provider, you have to weigh the risk versus benefit of the anesthetic that you're giving. So you only give anesthetics when you need to, because it has also been shown if you do surgery without anesthesia, that amount of stress is also not good for their developing brain. So then we come to pharmacology. We say that no one size fits it. You have to use weight for those calculations. So for every patient, pediatric patient you take to the OR, you must have a weight, and that is the weight you're going to do your drug calculation with. Then you have to think about the pharmacokinetics. This is what the body does to the drugs, and you have to think about the pharmacodynamics, about what the drug does to the body. You have to think about absorption, the effects that you desire after excretion. You have to think about common terms that are used in pharmacology and pharmacokinetics is the metabolism. Phase one, phase two, sorry, there's a typo there, it's supposed to be phase two metabolism. So phase one relies a lot on the cytochrome P450 system, enzyme system in the liver, and it's about oxidation and reduction, hydrolysis. And this in the neonates, the cytochrome system is not fully developed in utero and in the neonates, and will be ready about 6 months. So for children below 6 months, in your choice of drugs, you need to know that the drugs will not be metabolized. And that's why sometimes you find that the dose per kilo in the neonates is higher than in the older child, to account for that. And then phase two metabolism, this is getting it ready for excretion, the conjugation, and the glycosylation and acetylation. And this one rely a lot on the presence of proteins in the body. Again, how much protein is available will determine about this. And then bioavailability, we say it is about how much drug is available in the blood to do what you expect it to do. Then you will hear about first pass effect. This is what happens to the drug within the first one circulation. And all these are important factors because children at different ages, most of the systems will be ready for drug metabolism by 2 years. So children below 2 years, you have to really be aware of the drugs you're using and how they're metabolized and how they're excreted, because that will make a difference in your choice of drugs. Then, of course, we have these other aspects, cognitive, social, and emotional considerations. You have to think about separation anxiety. Neonates, they don't care who picks them. So long as they have been picked, they will be happy to go. Try picking a 2-year-old. They will be clinging to the mother. You're not able to get them out. If you don't do a good job, it becomes very messy. You have to think about separation anxiety, how you're going to deal with it. Are you going to do pre-med? Are you going to do parental presence at induction? This is also an area with a lot of discussion because sometimes the way our operating rooms are designed, they do not allow for parental presence at induction. And in other places, the parents themselves are not keen to come with the child when the child is is going into the OR. I've had one incident where I was talking to a 6-year-old with the mother, and I think they had Googled a lot, and they were asking very, very intelligent questions. So I kept answering, and some of them they were saying, "Is there a risk that I can die?" And I told them, "Yeah, there's a risk, but it's like this." Before I knew, the mother had fainted. So, and I concentrated so much on this kid who was looking so bubbly and knowing it that I didn't realize that the mother had fainted. So you have to weigh and look at what your parent is like. So you have to know that when you're doing pediatric anesthesia, from a social and emotional point of view, you almost have two patients or more: the patient you're dealing with and the community that is there with them, the parents, the grandparents, and we are in Africa, so the largest support system. Sometimes you have so many of them and they all want to talk, so sometimes you're called to do more than your normal call of duty, to do crowd control, to appease people and the like. As children grow older, depending on what their exposure in the hospital has been, they will have fear of hospital, fear of needles, fear of the white coats. I'm sure all these things you have seen. Then we have the other group of peer pressure, especially in our setup where sometimes boys are circumcised in the hospital. And some will say, "Oh, my friends were put to sleep. I want to sleep." Culture says, "Oh, they should feel the pain, so they don't want to do that." What their peers tell them, "Oh, you cried, you didn't cry," or whatever. So you have to deal with all that. And then there are other myths. I don't know whether in Nigeria it's there, but from the time they are small, boys are told, "Boys don't cry. Don't cry, you're not a girl." All those things are are important when you're dealing with your anesthetic. You have to understand where your patient is coming from and the community they are in. So then there is the communication model. The way you talk to a 2-year-old is not the way you talk to a 6-year-old, is not the way you talk to a 12-year-old. And this is what makes pediatric anesthesia interesting and challenging at the same time, because you have to make sure that you're communicating appropriately for the correct age, and make sure that you get feedback from your communication that you're doing a good job. So basically that is your conduct of anesthesia, and we now go to the other part. And before I get there, I would like to say that you have to be very good to give anesthesia to children. And that is why you are in school, and that is why you finish anesthesia, and then we'll say, now you need to do another 1 year fellowship, just learning how to give anesthesia to children, because children are not small adults, and it's a whole different ball game. However, it doesn't matter how good a pediatric anesthesiologist or how good you are at putting babies to sleep, you are if you do not have the support of the system. So you need to think about infrastructure. And this is why we are encouraging, and this is why we are telling you at your level these things, so that some of you can remain in the operating room giving anesthesia, and some of you can get out to make the system better for those ones who are doing clinical work to do a better job. So access to safe anesthesia and surgery for babies will rely on their ability to reach the hospital. So how are the roads in your catchment area? You have to think about provision of clean water and electricity and oxygen. the part that was exposed during COVID about how bad the oxygen ecosystem is in our setup. Sometimes these are not always guaranteed. And then you have hospitals that are dealing with both adults and children. And I've worked in both. In the children's hospital, everything goes according to your prioritization as a pediatric anesthesiologist, or as the pediatric surgeon, or as the anesthesia working there. When you come to a hospital that you're sharing operating space, you're going to do an obstructed hernia, then a woman comes with APH. Of course, the APH patient will get priority. Your baby is starved, you get dehydrated. So sometimes it will be good to have rooms that are dedicated for just children. And sometimes you have intensive care units that are also combined. And for some reason or another, the adults always seem to get the priority. Maybe because they're the ones who pay the money. I wouldn't know. So the other thing is about equipment and supplies. So there already exists a challenge in equipment and supplies, but when it comes to the pediatric system, it's even hard because remember, you need things that are a wide spectrum. If you're talking about, if you're running an adult service, even if you only got size 6.5 tubes, you can probably do like 80% of your procedures with that size 6.5. And if you added a 7, then you can do everybody. In the pediatric age group, you need from 2.5 to almost about 5.5 and 6. And you can't tell, you have to have each of them. You cannot say, as opposed to an adult, if you're going to do a cesarean section, and the only tube you have is a 6.5, you probably can use that in almost all the women. But if you are doing pediatric anesthesia and the only tube you had was a 4.5, it means all the babies below 2 years, you're not able to intubate them. It will not even allow. So when there is a problem with the supply chain, this is something we have to talk about, the supply chain for this equipment and prioritization, depending on who is doing what. We must make sure that anesthesia, and especially pediatric anesthesia equipment and supplies, are prioritized so that the supply chain support you can have. Otherwise, then we have to keep sending the patients to buy for themselves. When you look at the supplies, for example, if we look at drugs, most of the preparations come in adult preparation. So you have fentanyl. I don't know whether it's the same in your setup, but you have fentanyl comes in 100 mics, 2 ml. So what that means, if I have a neonate and I need 5 mics, I'll break the 100 mics. If I don't have another baby, then 5 mics I remove and the 95 I toss away. Very wasteful. If you look at paracetamol, if you have a 5 kilo baby and you need to give 100 milligrams, the other 900 goes to waste. So we really need to talk to even the people in the pharma to have things that are prepared for the children. So what happens is that when you have these drugs that you have to dilute to such high levels, you increase the possibility of drug errors. And sometimes you just need an alignment of things to make you have an error. So if you have fentanyl 100 and you only have a 10 cc syringe, it's very difficult that you're going to measure precisely 5 mics to give to the baby. So we really need to have that. And even if you look at laryngoscope blades, they range from 000 to number 2, ATT tubes. So everything, BP cups, you have the ones for neonates, you have for infants, you have for children. So it is a very specialized place that we need to think about. And there's no shortcut to that. Then we come to the elephant in the room about workforce, who is giving anesthesia to the children. According to WFSA, you need about 5 anesthesia providers for 100,000 population, just the normal population. And this is indeed a pipe dream for most low and middle income countries. And even when you combine the physicians and the non-physicians, we are still very far from attaining this ratio. Now, like in our setup, most of the physicians and even the non-physicians are concentrated around the urban areas because of other systems that don't work. You cannot send me to go and work in a remote place where there's no school for my children, for example. So what happens is that most of those providers are concentrated in the urban areas. So if you remove the numbers that are in urban areas, then you find that for the remote places, the availability of anesthesia providers is dire. And we haven't even touched specifically for people who are doing anesthesia for children. So we really have a lot to do in as far as that is concerned. So it is not only uh, that there's a problem with the numbers. There's also a problem with the training. There's no standardized training curriculum. So you don't know who can do what, and this leads to an increase in mortality and morbidity perioperatively. They say that if you operated in LMICs, you are more than 10 times likely to die than somebody who is a baby operated in the high income countries. And this is our reality, which we are planning to change. When you're still talking about workforce, then we have the other cadres. We are thinking specifically about the nursing care because there cannot be proper provision of safe anesthesia and surgery without nursing care. The nurses trained for perioperative care are very little and in short supply, and unfortunately, because this is not only in LMICs, the high income countries, because they can pay them better, take all our better trained nurses, especially perioperative and critical care nurses. They have a very hot market in the West. So what happens to our people? So we really have to train more and see how we can do this. So what are the solutions that we have? In terms of provision, the clinical conduct of anesthesia, there is no shortcut to that. You need to go to your books, you need to read the anatomy, you need to read the physiology, you have to read your pharmacology, and you have to put that into practice as you increase your skills and knowledge. So, but the one thing I would say that even with a lot of knowledge, you really need to learn to pay attention to detail. So, and I know I have not done justice to the clinical part because that is what most of you are looking for, but there is no shortcut. You just have to read. You have to improve your knowledge. You have to improve your skills, and you have to continuously update yourself on what is new and what is changing. In terms of infrastructure, we need a lot of advocacy. We need to entrench anesthesia and surgical provision in policies. For a long time, surgical people have been in there, or that we haven't been on the table when decisions are being made. That's why you find that there are lots of interventions like for pediatrics, the general pediatrics, diarrhea and vomiting, malaria, and all those things, because they realized and came out of the wards to be on the table when they're making policies. We need to do that. And this was the vision for developing the National Surgical Obstetric and Anesthesia plans. When you have solutions such as the Kids one, where they have dedicated operating room for children, that also goes a long way in ensuring that we have continuity. But we must emphasize about health system strengthening to ensure that you have proper supply chains and that ensures continuous availability of what is needed. We cannot do this without budgetary allocation. So what that means is that we have to make sure that we are on the table when the money is being divided. Otherwise, we'll continue being given the leftovers. When it comes to workforce, we need to train more people. There needs to be collaboration. You need to think about short courses, because if you're thinking about training an anesthesia physician, it takes a long time. It will take a long time to cover that gap that we have there. And we have to make sure that there's a way of keeping the skilled workforce in the LMICs in terms of compensation and quality of work, what they feel they need. Uh, Designing curriculum means that we can train the same. So if you have a curriculum that trains the people in West Africa, in East Africa, in South Africa, it means there can be movement even within our region. And we must remember, in terms of training, there's a lot of goodwill. People have realized there's a problem with workforce. But then we must not succumb to the goodwill of increasing numbers at the expense of quality of training and skill acquisition. All the trainings that are done, we must make sure that they're up to date, their quality is good. So this is why we are saying we advocate for short courses, even as we plan to do the full thing. And this is a place where surgery can help us. Surgery, they have gone a long way in their trainings, but most of the time they will realize that anesthesia is a rate limiting step for them. So we need to continue doing CMEs and making sure we support our workforce, especially mental health support. We need to have a culture change and prioritize safety even in constrained environment. When we give care to those children, let's do our best. Yes? And let's bring to the table all innovations vertically, horizontally, so that we avoid double allocation while other areas lag. So you might find that there are people who are doing the same thing using money that maybe could have been used to doing, but because the left hand doesn't know what the right hand is doing, then those kind of things happen. And a lot has been done to improve anesthesia. There are a lot of collaborations, and the World Federation of Societies of Anesthesia has been very supportive. The implementation of the safe courses. And at the end of the day, we realize that it takes a village to raise a child. We must collaborate to improve the provision of pediatric anesthesia care in this part of the world. And we must have global health practitioners emphasizing more on the provision of anesthesia. They have done a lot for global surgery, but not as much for anesthesia. And this is where we need to come out and say, yeah, we know you're doing so much for surgery, but your late limiting step will be anesthesia. What are you going to do to improve that? And in summary, I'll say that pediatric anesthesia and perioperative care has a lot of challenges, but these have been identified and there are concerted efforts to address them. We need to work together and encourage ourselves in LMIC with our friends from HIC so that we can come up with solutions that are best fit for all of us. Thank you very much. So we can have questions or anything else. You're muted. You're muted, Collins. No, you're still muted. It shows you're muted. I can't hear you. Sorry. It's showing a triangle where your microphone should be. You're muted. Are you still there? It still shows you're muted.
Can you hear me now?
Yes, I can hear you now.
Okay. Thank you very much for the wonderful lecture. Also about the myth that boys don't feel pain or don't cry. I think it doesn't still apply for only children. Up to this age, they still tell some of us that yes, you're a man, you are not supposed to cry, or you're not supposed to feel pain, or you're not supposed to show that you're actually feeling pain. So that aspect actually got me because it's still the same thing that I keep hearing even up to this age. I have some few questions, but I think I will allow the those that joined us in this webinar to let me. I want to know if any of them have some questions. Please, if you have any question, please indicate in the chat box. So I will invite you to the stage. Thank you.
Thank you.
Please, if you have any question, indicate on the chat box. Let me invite you to the stage, or you can drop your question on the chat box. Thank you. Okay, I think I'll go ahead with my question. Maybe when they indicate interest, I can invite them to the stage. Okay, I want to go ahead with my question.
Ask.
Okay, I want to know if there's any ethical consideration uh, regarding providing care to a child that is a child that the parents don't have any the best interest of the child at hand. So if you as a healthcare provider can step in and take decisions for the child that is best for that is the best.
That's actually a very good question because we know that when we deal with children, they're not able or legally allowed to consent for the procedures that we do. So, unlike in adult practice, we take consent from the parents on behalf of the children, and we hope that the parents have the best interest at heart. However, there are cases where we know that we need to do something from a clinical perspective, and the parents are not keen to do that. For example, we have maybe a kid who we need to take to theater, and we know we are going to need transfusion, and the parents are Jehovah Witnesses, and they say they do not want their child transfused, and in the best interest of the child, we know that the child will need the blood. So in my country, we have children officers, uh, social workers that will allow you to do that and get consent from a court, like a court order, to go ahead and do that. In cases of emergencies, they have vested that power with specific people in the hospital or in the healthcare system. And that also occurs where you need not only the transfusion but any life saving procedure that the parents are not keen to have. And it's also the same process that we use when children have been brought, but they don't have a legal person who can sign the consent for them. So ethically, you need to find out what is the procedure in your country about those kind of things. For us, you have to use the children's officers and the social workers. I hope I've answered your question.
Yes, man, you did, man. Okay, man, I have another question. Okay, majority of the anatomy and physiology we showed us earlier, I think is based on a healthy child. So I'm not asking if is the care for a child that is critically ill or disabled, is it different from critically or chronically ill? Is it different from caring for a healthy child?
Yes. So the reason I showed you the normal is that because you have to start from the normal before you work with the abnormal. Okay? So we know that when we are talking about, let's say, the sick laparotomy, the kid who with intestinal obstruction or NEC, that the physiology is really, really deranged. So, and the degree to which it is deranged will also determine even your risk classification for that child. If we take, for example, a kid who is severely dehydrated, going for surgery that is emergent, or then you know that you know what is the normal there, blood volume. So now you know that the blood volume has been decreased by this much, and how are you going to deal with that? When you talk about a kid with fevers or very sick, then you know that their metabolic rate is even higher than it normally is. So you're talking about respiratory support. You're talking about adding glucose to their waters because they're not able to generate. The reason
Hello.
Hello.